Well, hello, everybody. Welcome to the first in conversation of 2025, and something of a departure, actually. As you know, in this series of chats, we speak to key opinion leaders across the health and care sector in our country and beyond, usually external to ABHI, but of course, we have a number of those individuals within our own organisation. So I'm delighted that we'll start the year with our very own Executive Director of Value and Access, Luella Trickett. Luella, normally at this point, I ask people to kind of introduce themselves and give us a sense of their background, but I'm going to take it as read. I guess most people watching, listening to this will know you, have worked with you, and be fully aware of your tremendous range of experience and expertise in all things related commercial aspects of the sector. So what we're going to do for I know 15 minutes or so now is kick around. We're recording this at the end of the first week back in January, really, for most people. A publication that came out this Monday from the Department of Health and Social Care called Reforming Elective Care for Patients. So this is not the 10-year plan we're all waiting for, which I was telling everyone will be here in May. It's now everyone's saying it's going to be here in June, but it is related in part to the spending review. And the Chancellor's got herself in a bit of a pickle, I think. If she said there's only going to be one fiscal event a year, and if she follows her own fiscal rules, then it might be a little bit tricky. So we'll watch June, but that's a 10-year plan bit. This actually, the first thing that struck me about it, well, was it's a very, very political publication. It's designed to meet the plan for change that the Prime Minister launched in December. That was his relaunch of the government, and that commitment to restore the constitutional marker, which we may have forgotten we have an NHS constitution, which has some legal rights and some responsibilities in there. But to return to that RTT, we'll drift into acronyms. I'm sure that referral to treatment time of 18 weeks for 92% of people by 2029. Why 2029? It's because that is the likely date of the next general election. So that's bit of a gamble, I think, on his part, but overtly political. And there's a few milestones along the way. Luella, what were your thoughts on first read?
So my thoughts on the first read were there is nothing in that document that people would disagree with as an ambition. And probably anyone who keeps up with health policy and the state of play would not be surprised about any of the proposals in there. I suppose for me, one of the biggest questions is, in the current fiscal environment and bearing in mind the cap on the additional money flowing into delivering elective care being effectively put back in place because it was uncapped previously, who's going to do this? And where's the money going to come from? Because the more you do, the more it costs. The way in which the trusts can balance their books is by doing less. The Specialised Services Device Programme, by all accounts, is overspent already this year. It's not overspent because they are buying ever more expensive devices. It's overspent because they're buying more devices because they're doing more elective care. So, how is this going to be done within that financial envelope, and who's going to do it? Now, I'm not ABHI's diagnostic lead. Nishan is our expert there, but anybody with half an eye on what's going on will understand that a commitment to open the community diagnostic centres, so the CDCs, 12 hours a day, 7 days a week, laudable, will deliver more diagnostics. Who is going to man those centres? Who is going to look at the results? And as a result of the results, pardon the pun for using two words at once, how are those patients then going to feed in? Yes, doing early diagnostics and diagnosing to prove that no further treatment is needed is going to help the waiting lists. But we do still need to manage those that are found to need follow-up care. So those are my initial thoughts. I've probably got other thoughts on the elective centres, but I'll pause there and let you kind of come back at me, Richard.
Yeah, let's come back to the surgical hubs. That's people have been asking us a lot about those, and actually we're going to pick up the CDC. There's community diagnostic centres in another version of this. We have a colleague from NHS England who's happy to speak to us. He's just got to get it through their internal communication. So we'll probably do that this time next year. There is a lot of talk in there about financial reform. Um, Details yet to follow. The one thing that the one thing that is firm in there is advice and guidance. This advice and guidance option, which has been around a while, and the bung that GPs are going to get 20 quid for every time they take this. GPs are pretty good at responding to financial incentives. I remember way back in the early 90s, the GPs of South Wales nearly bankrupted the NHS, where there were incentives for fund holding practices to introduce clinics, and they ran all sorts of clinics, none with any patients in, but they were funded in. So that'll be interesting how they respond, and there needs to be a response. Obviously, the other side, it's all very well the GP asking for advice and guidance. There needs to be someone there. And then the other thing that took me was that the talk of higher tariffs to specialties where there were particular problems. Now, I wrote in the blog, actually it's going out later on today, that the NHS is not in the business of discontinuing unprofitable product lines. But I just wonder, have you got any sense what we might see in some of those financial incentives? And what about the risk of gaming from the provider sector, where they see they'll go for the higher tariff stuff? And what effect do you think? How much are our GPs going to derail things with incentives for advice and guidance?
So the GPs absolutely will respond to that. It is a way of demonstrating a steady and reasonable income stream, and quite frankly, it'll probably help them with a lot of the patients where they would like to refer, but in the current environment, they know the referral will be so long in coming that they'll probably still have those patients coming back to them on a regular basis between that referral and them actually being seen. So they will want it. The difficulty is that the specialties that they're wanting the advice and guidance from in the secondary care sector are under a lot of pressure. So how can you have a piece of their time? If you think of the average secondary care clinician, they have their PAs, their time scheduled in the NHS. They have a certain number of scheduled blocks, but those blocks are filled with things that they do. So if you're a surgeon, you'll have your outpatient blocks, you'll have your surgical blocks, and you may, if you're really lucky, have one block of time that's for admin. And believe me, there's a lot of admin for them. So when are they going to do this advice and guidance piece? I am quick to say it will vary specialty wise, because the physicians may be under a different level of pressure for when they have time that they could potentially do advice and guidance. Is this going to have to be factored in to their regular clinics? And if it's factored into their regular clinics, then that could be helpful, because it's, instead of seeing a patient for 20 minutes, they may be able to do 2 advice and guidance calls. We have to see how that operationally plays out. So that's kind of my thoughts on that. But you're right, the GPs will want it, and it will help GPs in their overall management. I think that's my personal belief. When it comes to the funding for elective, yeah, you're right, Richard. They have to get those tariffs right to stop the system gaming. We know that the system has been seeing the previously uncapped elective funding as a solid work stream. Do they do the calculation well about the tariff coming in and the cost of delivering the service? I'm sure some of them do it really well, but I'm not sure all of them do. So it may not mean that just because they're doing a lot of elective work and getting that tariff payment, that they are actually balancing their books. The best practice tariff concept back in the day was very successful in getting trusts to do things the way that the system wanted to see things done. Now, often that was an outcome-based thing. Here, they're going to have to be very thoughtful about how they do it on a productivity-based thing. Really, in order to reduce the waiting times, they're going to have to target the best practice tariffs onto the longest troublesome waiting lists. And one could argue that the most attractive for the trusts is the straightforward care. So perhaps some of the orthopedic work, perhaps some of the more straightforward cardiovascular procedures. But once you move into the more complex and perhaps less predictable procedures, you are getting into okay, what best practice tariff is actually worth doing the work for? It reminds me a little bit of sequins. Often the feedback on sequins was it was so much hassle to deliver the sequin that the money that you got as a result wasn't worth it. So I hope that NHS England are very thoughtful about how they put these best practice tariff type approaches in place to drive the right delivery. Into the piece that's in the document about using the private sector. Now, the NHS has been able to use the private sector. There have been agreements to use the private sector since way back when, and that was very much a live conversation immediately post-COVID. Some of the problems that existed then remain now. The NHS has to be better at giving commitments to the private sector for lists that they are going to fill with patients. Otherwise, the private sector sets aside time and then they're not filled. And that's wasted time that they could have given to their clinicians to deliver either their insurance or their self-pay care. So that'll have to be got right. But equally, there's the same challenge that you always get, that the consultants are the ones that are doing the work in the NHS and they're doing the work in the private sector. So how are you going to incentivize those consultants to do work in the private sector at NHS tariff that otherwise they may be doing in the private sector at other tariff, bearing in mind, and this sometimes gets forgotten, that all of this work is being done in their own time. It's not being done in their NHS hours. So that's another consideration.
Yeah, it's great. I mean, the private sector thing there, it was billed as if it was new. Of course, it's not, as you rightly said. The NHS has always used the private sector when it gets when it makes sense to do so in terms of when it needs capacity. Very often it has the capacity, so that's going to be an interesting dynamic. It's probably a little bit overstated. Yeah, there is quite a lot when there isn't about best practice tariff, and yeah, I've waded through the thing 2 or 3 times now, and there's talk about using best practice tariff and reform of elective care in 5 specialties, and I have been scratching my head for a little bit, talk about cardiology, NT, gastroenterology, urology and respiratory, but I think that there are areas that have been targeted where you can actually take some of that work into the community out of hospital. So that's going to be an interesting one to follow, and obviously to enable that, the role of technology, and that the technology that many people listening to this will have are going to be very important now. So let's get on to the elective hub thing. Big call. We're getting a lot of interest about them. People phoning us up saying, well, when are they going to build the surgical hub at the end of my street? I was actually on the board of a hospital that went through the accreditation process. And actually, what it achieved really, I mean, and this is not without merit, it was a bit of a morale boost for our staff. We had to demonstrate to Tim Briggs's team that we knew what we were doing, and we got a badge and we were kind of accredited, which was good because that then mainly helps us with going to commissioners and saying, look, well, you should be referring your patients to us because we're accredited, and that will actually come back down. Also, the other piece in there, which was called out actually from the very start of the document, was back to that NHS constitutional right of patient choice, which again, it's a slightly contra, isn't it? The integrated care cooperation way we're going with the NHS now, where you can choose via the NHS app your provider. What would you have to say to people about it? And people are asking us a lot about elective surgical hubs. What are the significance of them? How do we engage with them? And actually, as we're recording this next week, we do have David Lawson from the Department of Health and Social Care is going to come and speak to our orthopaedic group about the surgical hub programme. So what's your take on it, Luella?
So there is a lot of logic to creating a hot and cold environment. If you've got a cold site where you can plow through the routine work, not distracted by what's happening in A&E, what's coming through the emergency route, you can get through a lot more patients, and you don't have that challenge that you often face otherwise of having to cancel patients at the last minute, which is soul destroying for the patient, very challenging for the family, and may disrupt all the plans that they've put in place to be able to come in and have their procedure. So there's a lot of sensible rationale behind it. The difficulty is, how do you deliver on it when you may not have the infrastructure in place locally to do it? So, in some cases, the one you're talking about, there was already a hospital that could do that and was set up to perhaps be able to do it without any challenge. In a lot of other places, they either have to build a facility or somehow carve out a facility and staff it separately from the main facility. So you've got the kind of operational delivery of it. Once it's there, it absolutely, does the right thing. And orthopedics is a poster child for this because it has been doing it. Swellyock's been around, Southwest London Elective Care Centre has been around for a long time. And the demonstrated outcomes from these dedicated centres is uncontroversial, to put it that way. Doing it for some of the other specialties may be a little bit more complex. There were already a number accredited, so you could argue that this is restating something that is already in existence. Doing more of it is absolutely the right thing. Your question about patient choice, really interesting. You probably do have patient choice if you live in Surrey or in Manchester or any of the other sort of conurbations where there are more than one provider that has all the skills and the specialties and the capabilities. Where it becomes somewhat of a red herring is when you move to more rural areas, less populated areas where there is less infrastructure. If you're in, and you know this part of the world well, Richard, if you're in the southwest, you really don't have much choice unless you're willing to drive 200 miles. And most people need their support network around them when they're undergoing procedures, unless you are young, fit and healthy otherwise than needing your procedure. You're going to need that support network. So while giving people choice is a practical and real solution in some parts of the country, in other parts of the country, it's just words.
Yeah, it's interesting. If Chris Whitty was listening to this, he'd be nodding and saying one of the great challenges we've got is that part of the demographic challenge we have is that when people start retiring, they tend to want to move to rural and coastal areas at the time when they need some specialist healthcare. And specialist healthcare, as you pointed out, tends not to exist in rural and coastal areas. So just finally then on that, there is quite a bit in there about the NHS app and being able to book your own appointments and increasing use of what's known as PIFU, that patient initiated follow-up. So you don't go back for routine follow-up and unless you actually decide you need it. There are a lot of things in here that sort of reflected back to me. There's nothing new in here, as one or two commentators are pointing out. This is just a compendium of things that are happening in the service already. We may have to wait for that 10-year plan for any really new and radical ideas. But this seems to me to be pushing quite a bit of responsibility back to individuals and also kind of thinly veiled attempt, which was the NHS long-term plan, keep people away from the NHS estate until they absolutely need to go on. What's your take on that, Luella, finally?
So the idea of being able to book your own appointments is to many of us quite appealing. If you've ever received a letter from the NHS telling you when your appointment was, and looked at it and gone, that's just not going to work for me, because I'm in the workplace, I have a job to do, there are certain things that I can flex, but there are other things I can't flex, might have childcare commitments, etc. The idea of being able to book your own appointment is very attractive, but it's not attractive to everyone. So, like all these things, if we can channel the proportion of people for whom it's a good thing to use it, we do free up time. But we have to make sure that the other routes to making appointments and having those conversations are still available. I had an anecdote the other day where a very with it lady in her late 80s said she'd taken a stroll to the GP because she needed an appointment and she thought it would be good exercise. She got all the way to the GP and the receptionist said, you have to book your appointment online. And this particular octogenarian was perfectly capable of booking it online. That's not true for all. That's not true, not just for octogenarians, but it could be true for somebody much younger for whom this isn't the way forward. But this poor person who'd done the exercise had to walk all the way home to do her appointment at home. She couldn't even do it in the practice. Ridiculous. So on the surface, attractive. Let's get people who can do it doing it, free up time for other people. Got it. Great. Patient-initiated follow-up absolutely assumes that the patient knows when they need the follow-up. So, again, has to be done carefully. You can't just say to a patient, right, that's it now, I am done with you unless you think you need to come back, because there will be a cohort of the population that don't want to bother the doctor, and they will stay at home deteriorating. So we do have to make sure that that patient-initiated follow-up is done in a, dare I say, protocol-driven way, so that the patient-initiated follow-up is for things where there is a surety and a security that the channels are there. You know, you and I, if we were told that we had every right to decide that we needed to be seen again, we'd probably have an inkling of when we needed to be seen again. That's because we work in the health environment, we've got some knowledge, we've got the understanding. If you haven't worked in the health space and you don't understand health, you might not read the signs, you might not know. And I think sometimes I do reflect on that when people talk to me who have not been involved in the NHS. And I'm a bit, first of all, I'm a bit astounded at how little they know, but then I have to rein myself in and go, hang on, Luella, this has been your life for 30 years. Of course you understand it. You know, said person may be highly intelligent, you know, a high-flying lawyer in the city. They don't have any health background. How would they know? So we do have to get that right.
Yeah, and it's one of the kind of juxtaposes in here, isn't it? I suppose writ large throughout the document, which struck me as well, was the desire to try and address the health inequalities we see. But you just outlined how the sort of digital inclusivity and that digital exclusion may kind of play into this as well. It did strike me as well. So that's been great. Look, we've covered everything I think I wanted to cover on the document. I would encourage people to have a look through it. It's not a bad read. It's quite long. There is a summary of the commitments at the front and lots of the usual commentators, Roy Lilly, HSJ, Providers et al. Have all got their own commentary on it. So do take a look at that. So final then, Luella, let's wind forward to the next general election. So alongside you and I probably having decided we still can't quite afford to retire. Bearing in mind we haven't got close to those constitutional targets for quite some time now, what's your bet on where we will be with the RTT target in 2029 when people are going to the ballot boxes, and Keir should have that stonky majority, which will see him through at least another term, but this may be. It may well hinge on this. What's your bet on how close we're going to get?
So they've hung their hat on this one single metric, and there are other factors that impact that metric that all of us recognise, social care being probably a very large one. The commentators prior to the Labour's commitment to this in the first place, in the early days, was it may happen naturally anyway. So he may be lucky in that some of it happens naturally anyway. The elephant in the room is the current reliance on economic growth for us to be able to fund public sector services throughout the term of this Parliament could be the problem, because you and I are all being told, every conversation we have with anyone in the health system, 2025-26 is going to be worse than 24-25. That's quite a tough starting point to be able to deliver an ambitious transformation in a target that hasn't been hit for several years. But if it's naturally going to happen anyway because of the way things will play out, maybe they'll be okay. The public will not forgive them if they haven't hit it, though, because they have made it such a black and white commitment.
Yeah, big gamble, isn't it? And it's inauspicious start in the announced on the at the beginning of the week that they're going to hit this target by the end of the week. Was it 15, 20 of our biggest hospitals are in a state of critical incidents, which means a lot of this work isn't happening at the moment. Everyone is manning the front door of the hospital.
Yeah, and actually, if you look at that list, some of the hospitals in the list, I would expect there to be there. There are some hospitals on that list, and I'm going, the demographics of that hospital, why are they on the list?
Well, we'll come back to this. We'll return. We'll be back for more on CDCs, certainly. Well, this has been a great chat. I hope people have enjoyed it. And I'm sure there'll be lots of questions coming in as and when this goes out across the wires. Thanks very much for your time this morning.